Thank you very much for the kind introductions. It's a real pleasure to be here at the European HIV Clinical Forum, speaking on behalf of children, the new treatment options for children and adolescents. So my main points today are going to be to speak a little bit on the importance of adolescents related to antiretrovirals, and then go through several new indications of drugs, of antiretroviral drugs for children, as you can see. So the first thing is a few words on antiretrovirals in adolescents. So the good news is that nowadays antiretrovirals for adolescents are coming much earlier than they were before. In the early 2000s, for example, you can see tenofovir TDF took almost 9 years to be approved from adult approval to adolescent approval. And that has gone much faster later on. And you can see that bictegravir was approved for adults in 2018 and in adolescents in 2019. So good news. But still, there is a lag that we could try to cope with. And this is that based on that dosing recommendations for antiretrovirals are the same for adults and adolescents that meet the weight criteria. There is no difference in pharmacokinetic characteristics from adults. Therefore, a group of people wrote this white paper saying that we should advocate for including adolescents in phase 3 antiretroviral clinical trials or perform specific adolescent trials in parallel. Moving forward, there is very exciting news about the efficacy and safety of dolutegravir in children and adolescents that has been recently presented. So at CROI this year, Odyssey results, final results have been presented. Odyssey is an international multi-center randomized non-inferiority trial to compare the efficacy and safety of dolutegravir with standard of care in children and adolescents starting first or second line antiretroviral therapy. And the main trial included children over 14 kilos. This was kind of like 2 trials in one. You can see that we had Odyssey A for first line antiretroviral and Odyssey B for second line antiretroviral. And in both, we were comparing dolutegravir with standard of care. And this was presented by Anna Trukova on behalf of the Odyssey team. The population at baseline, you can see that the median age was 12 years, so many adolescents included. Several had a WHO stage 3 and 4 of 26%, and most of the children and adolescents were African. You can see on the right that only 4% of the children were recruited in Europe, and the most recruited sites were in South Africa, Zimbabwe, and Uganda. And baseline antiretroviral in standard of care in Odyssey A was efavirenz, 92%, and in Odyssey B was a PI, 72% lopinavir ritonavir, and 25% atazanavir. So the good news is that the primary outcome to show the proportion with virological or clinical failure at 96 weeks, you can see that there was a significant difference in favor of dolutegravir compared to standard of care, a total of -8% and a confidence interval of -13.4 to -2.6%. So that not only showed non-inferiority, but it also showed that dolutegravir was superior to standard of care in this trial. Okay, so not only that, we evaluated the associated clinical events or death of any cause, and you can see that overall there was a low number of new or recurrent HIV events in both arms. Most events were WHO4, and there were 5 deaths, but similar in both groups. Related to adverse events, there were a similar proportion of participants in dolutegravir and standard of care arms who had one or more SAEs. Most of the SAEs, you can see 84% were hospitalization. And there is a significantly higher number of grade 3 events in standard of care in Odyssey B, but this is because of raised bilirubin of atazanavir that we know is very common and not important. And important, more antiretroviral therapy modifying events in standard of care than in dolutegravir. There were similar CD4 count change from baseline to the 96 weeks. A small increase, but we don't really know if it is statistically significant is, but we don't really know if it is clinically significant. So in summary, and this is great news for children all over the world, is that dolutegravir has been shown superior to standard of care based on virological and clinical failure by 96 weeks. No evidence that the treatment effect was different in children starting first line versus children starting second line. There were no safety concerns on dolutegravir, and these results support WHO guidelines and now also American and Penta guidelines on current rollover to dolutegravir-based regimes for children starting first line or second line antiretroviral, allowing harmonization with adult treatment programs. Moving to not only dolutegravir in adolescents and children, but the possibility of infants. So because of the Odyssey trial, we knew that dolutegravir 50 milligrams, the adult tablet, can be used in children over 20 kilos. And this is very nice because we can use the adult tablet for children above 8-9 years of age. And this is good news, especially for the low-income countries that usually have enough adult formulations and not so easy to get the pediatric formulations. But what happened for children below 20 kilograms? You can see the combined results by the Odyssey team and the trial, and also the impact trial on dolutegravir, showing that with dolutegravir 5 milligram dispersible, we found in different weight bands, we found a good concentration for children depending on the dose. This was presented at IIS 2 years ago and is now preparing for publication. But this allowed for the approval of dolutegravir 5 milligrams dispersible tablets in children less than 20 kilograms. And this is fantastic because it's a tablet that is dispersible in water. And depending on the weight band, you can see from 3 to 6, 6 to 10, 10 to 14, or 14 to 20, the different doses once daily on a very easy to take dispersible tablets. So this has been now approved by FDA and EMA, and this will be available in most of the Western countries. And also this allowed for lower income countries, 10 milligrams dispersible to be also roll out very soon. There is other options, bictegravir in children and adolescents. So another integrase inhibitor that have been approved in adults, and it has been approved in adolescents, but there is recent data of the pharmacokinetics, safety, and efficacy of bictegravir in children from 6 to 12 years. This is a smaller trial, not to show efficacy, but mostly to see safety and PK data. So this is a small trial on virologically suppressed children, 6 to 12 years, over 25 kilos. In the part A, there was an intense PK, and in part B, none. It was shown that the intensive pharmacokinetics data compared to the bictegravir emtricitabine TAF in adults was similar and the area under the curve was similar in children and adults. Because the size of the trial could not evaluate virological efficacy, but at least it was shown that all the children maintained the virological suppression at week 24, and CD4 counts remained well. No participants met the criteria for resistant analysis. Something very important is that bictegravir intracitabine TAF once daily tablet is a small size tablet, and it was evaluated the acceptability, and you can see that the adherence rate was very high, up to 98% of the adherence rate. So this is great news. This allowed for the approval by the American guidelines of having bictegravir in children over 6 years and 25 kilos. But not only that, also we have new data on TAF in children and adolescents. And you can see that from the same trial, the bictegravir trial, it was evaluated the intensive PK data of both FTC and TAF, showing that exposure of FTC and TAF were consistent with safe and efficacious ranges from historical data in adults, allowing not only for the combination of bictegravir and emtricitabine TAF, but also the combination of emtricitabine and TAF in one single tablet is also available to combine with other drugs apart from bictegravir, also over 25 kilos. So good news for children that have now available TAF in a single tablet with emtricitabine, or with a single tablet and only treatment with bictegravir. And you can see here that also the size of emtricitabine TAF is much smaller than the one combined with TDF. And this is important for children between 6 and 12 years because of the size is important for swallowing for these young children. Okay, and last is the information related to abacavir in infants. We know that abacavir is one of the main treatments for children, and it has been approved for children over 3 months. With the new diagnosis in the last years, we are making diagnosis in children much earlier, and now with the PCR at 6 weeks or even in the neonatal period, we need the best drugs to be available in children and infants. So, as I mentioned, abacavir has been approved for children over 3 months. And for pediatricians, abacavir has been and still is a fantastic first NRT option for children. And abacavir plus 3TC is the combination of choice for us pediatricians, and in the recent guidelines that are nowadays in a draft for the 2021 guidelines that will coming out soon, but also from the previous guidelines, we believe that the combination of abacavir 3TC is an excellent combination for children. And you can see on the right the data from the ARROW trial, Penta 13 and Penta 15, showing the benefit of abacavir both twice daily and once daily. Well, as I mentioned, abacavir in children less than 3 months has not been approved by EMA or FDA. And the dose is usually for children over 3 months of 8 milligrams per kilo twice daily, or 16 milligrams per kilo once daily. So last year, it was presented this study by Tim Creasy, which is Impact P1106, of the possibility of using abacavir in children from 1 month to 3 months. And you can see that this was a phase 4 opportunistic pharmacokinetic study, and they included children that started lopinavir ritonavir plus 2 in RTIs and measured the PK of the children with abacavir. You can see on the right that very interestingly, the mean individual predicted abacavir concentration versus the time curves, you can see in black the reference for adults, and you can see that the different PK curves follow very clearly the adult ones. So this is very interesting, but because allowed that this abacavir syrup in children from 1 month to 3 months could be an option for children. The safety in the trial was good because although there were several grade 3 or 4 adverse events, all of the grade 3 or 4 adverse events were assessed as unrelated to abacavir. So this is very important because the results from IMPACT P1106 trial plus 2 observational cohorts provide reassuring data on the safety of abacavir initiated at 1 to 3 months of age. And it is now recommended both by American and the European guidelines. And the dose that has been accepted is abacavir 8 milligrams per kilo twice daily. But what about below 1 month? So abacavir in less than 4 weeks, it has not been yet approved by the guidelines, but there is very recent data on the use of children less than 4 weeks. It was presented at CROI this year by Adri Becker and her team. And what they did, it was pooling data from 3 different studies, administering abacavir liquid formulation. So it was PACTG321 Tiber cohort and the IMPACT P1106 that I mentioned before that also had children below 1 month. And they did the Monte Carlo simulations to identify the optimal abacavir dose to achieve exposure in the range expected. So what they found is that although abacavir elimination is greatly reduced at birth, rapidly increases over the first week of life, and abacavir clearance in low birth weight infants at 6 weeks postnatal age is equivalent to those in term infants at age. So their proposal is for children 0 to 4 weeks, the dose of 2 milligrams per kilo twice daily to be the appropriate dose. This has not been yet approved, but opens a fantastic window of opportunity to start abacavir from the diagnosis of a child, even if the child is 2 days or 5 days. So these were the main new treatment options that I wanted to present to you. Thank you very much. Thank you, everybody.